that, and we'd love to know as well. So welcome everyone to our webinar today. You're joining a webinar, Taking Action on the Root Cause, Inadequate Income and Food Insecurity. On this first slide here, you'll see teleconference information. If you have any problems or challenges accessing or hearing with any of the technology, please let us know. We'll do our best to tell you what slide we're on and try and keep things clear for you, recognizing that not everyone is viewing this on the screen, that some people are listening by audio only. There we go. So my advance is working. So if you have questions or want to share any resources, please feel free to do that at any time as we go along through the webinar. Put your information, your links, your questions into the chat box. We will address questions after all of our speakers have finished and after we've gone through the webinar, but we'll keep a little record along the side. So if you think of questions as you go along, please post them in the chat box and we will get to them in a bit. So I'm Diane Oikeld, and I'm here with the National Collaborating Center for Determinants of Health, and I have two people in the background here who are helping me out. One is my colleague Karen Fish, who is also a knowledge translation specialist, and Karen will be posting some links and some resources up in the chat box and helping me with questions. And we also have Danielle McDonald, who's our research assistant, who's working the back end of the technology. And actually, I don't have the picture here, but we actually also have Anna McNeil, who is our communications assistant, and she is helping while Danielle's temporarily in something else. So lots and lots of support on this end. So thank you to my team. And we have three main speakers. I'm really just a facilitator today. We have three main speakers that are going to fill you in on this topic. We have Megan Martin, who's a community health specialist with the Fraser Health Authority in British Columbia. Tracy Woloshin, who's a public health dietitian at York Region Public Health in Ontario, and Christine Johnson, who is a health equity lead at Nova Scotia Health Authority. And she's actually in Antigonish, but in a different office than me right now. And I'll introduce them in more detail in a few minutes here. Today, the focus of our webinar is really on inadequate income as the root cause of food insecurity. And so our focus is on income-based household-level food insecurity. We're not intending to have an in-depth discussion about all of the possible programs that address food access, food skills, food security as a broader initiative. We're not talking about all the different ways that the various aspects of food insecurity can be addressed. It really is intended to be a focus on the income policy-related solutions, recognizing that there's definitely beneficial work that happens in the other pieces. We're talking about how public health can engage with communities to address food insecurity and what the social justice role is. And we've made a real effort to try and come up with practical and pragmatic suggestions for action after today. So we'd really like some feedback on that as you're filling out the webinar or the evaluation. Hopefully we're getting it. Hopefully we're going to leave you with some actionable items, and we'd really love some feedback on that. So before we get too deep into it, we do have a polling slide here that I hope is set up. We want to get a sense of where everybody works and where you're from. And I see that it's up on the right there. So if you could take a minute to let us know where you're calling in from. We can have some live feedback here from people. I would love to see someone from every province and territory, but we'll see. We have sometimes had people from international as well, so we'll see what we come up with here. No one from, someone from the U.S. though, so that's good. Okay, that's good. The Ontario, some BC. I'll just leave it for a couple more seconds. If you can vote there where you're calling in from, that would be great. Oh, and someone from the California Department of Public Health. Hi, Anna, welcome. This is great. Okay. Oh, this is great. Thank you so much, everyone. Okay, I think we can close that now. And please feel free, if you know of people who couldn't attend today, if you want to send the information in the slides, then that would be great. And so now we want to get a sense of what your role or your position in public health is. This tells us what type of position you hold, perhaps what your profession is. I know I spent over 15 years in public health in Ontario as a dietitian, and a lot of times it's dietitians that do this type of work, but not always. And so we really wanted to get a sense of the variety of people that have an interest, and that tells us where we might be able to make some connections. So that's great. We've got community development, some health promoter, nurses. Other. If you checked other, I'd love if you could put into the chat box what that other means, because that will give us a sense of what our reach is. Oh, that's great. Great. Thank you very much, everyone. Thank you very much. Okay, as you know, we are the National Collaborating Centers for Public Health. I won't spend too much time on this. Many of you are already familiar with where we are. We are in Antigonish, Nova Scotia. We're the National Collaborating Center for Determinants of Health. I'm sitting at St. FX University, but we have 6 centers altogether across the country. And then this is a slide a little bit about what our center specifically does. And you know, more and more our focus is on general, broader health equity. And today we're looking at the food insecurity piece as it into that bigger picture of health equity. And so now on slide number 9, we're really looking at, oh, I lied, it's slide number 10 actually. These are some of the key terms that you will hear us talk about today. So the reason I put this up is because there's a lot of terms in this type of work in public health that sometimes get conflated is one word, sometimes get used at each other, and this is partly to help us focus what the discussion will be today. So there's food access really is a component. There's an economic component of food access, and food access is also a component of food security. Food security is a larger, and it's an aspirational concept, a really broad term that's used in a number of different ways. It exists on multiple levels, and it's often a catch-all kind of term for a lot of community-related programming that happens in public health. The public health rules around food security really are essentially twofold. They're to focus on the underlying issue of not having enough resources and to have secure access to adequate food. And then, of course, poverty is what increases the vulnerability of households to food insecurity, or to food security. But then it's also to enhance those local and community food systems within the global food system. So food security is a bigger, broader term than the food insecurity piece. And the food insecurity, of course, is the focus is on poverty, and as poverty increases the vulnerability of households to food insecurity. So, if we eliminate household food insecurity, then, we will feed into food security, and it feeds into a situation of one that is more food secure. So, again, the focus today is on the insecurity and public health action on the income-related policies that will address it. And I've had a lot of discussions with people over the past couple of weeks about this topic, and someone once said to me a while back, I'm probably going to get the quote wrong, but they said it's one thing to have compassion for the struggles that people have, but it's another thing to be able to look at why they have to struggle, or to have compassion or want to act on the reasons of why those struggles exist. And essentially it's the saying that of course we all have compassion for people who don't have enough food to eat, and of course we want everyone to have enough food, and we want to help fill that need. But when we address the underlying reasons of why, that really is looking at equity. So the reason that people don't have enough is because they don't have enough income. The reason they don't have enough income is because of that disparity in how income is distributed. So it's sort of looking at how does it relate to the bigger picture. So we want to have compassion, and we want to have drive to tackle the reasons of why the struggle happens in addition to the struggle itself. So with that, I am going to introduce our first advisor. Megan Martin is a community health specialist with Fraser Health in BC. She works to build partnerships with municipalities and community organizations to address the social determinants of health. And although Megan is the voice of Fraser Health on this webinar, she actually has two of her colleagues in the background that have helped her prepare this, and they will join us for the question and answer at the end, and that's Laura Ludon and Brenda Ailis. And they're also on the line. They're going to present at the Q&A. I think I've just gotten a note that Megan might have gotten logged out. So I am going to pause. She's going to speak about recent activities at Fraser Health, including development of a strategy document. And that strategy document is to prioritize work on poverty reduction as part of the food security initiatives and help guide discussions and the food security work that's done in the communities. So with that, I'll introduce Megan, and I'll pause. Megan, are you there?
I am here. Are you able to hear me?
Yes. No, we're good. Sorry, I just got nervous there that you were gone. So I'll turn it over to you. Thank you.
Okay, perfect. Thank you so much. And thank you for inviting me to participate today. I'd like to begin by acknowledging that Fraser Health's work takes place on the traditional territory of the Coast Salish peoples, and my colleagues and I are extremely grateful for the opportunity we have to live, work, and play in this part of the world. So I'm advancing to slide number 13, the BC picture here, and I wanted to start my presentation by giving a bit of a picture of the food insecurity landscape in BC. So food insecurity is recognized as a serious social and public health problem affecting over 1 in 10 households in BC. And over the past few years, we've observed food insecurity gradually increasing in BC. Poverty is the strongest predictor of household food insecurity, and 76% of households on social assistance in BC experience some level of food insecurity. Interestingly, among seniors who receive public pensions, only 12% are food insecure. Some of you may have seen a recent article by McIntyre and colleagues in the Journal of Canadian Public Policy, which suggested that the guaranteed annual income that seniors receive plays a significant role in reducing rates of food insecurity in this demographic. So this reinforces our understanding of income as a key driver of food insecurity. Despite high levels of poverty and an increasing prevalence of food insecurity, BC remains the only province without a poverty reduction strategy. Community-level food programs such as school meal programs and community gardens remain the dominant response to issues related to the food system. And while there are many positive benefits of these programs, which should be acknowledged, they have limited capacity to resolve income as a root cause of food insecurity. So going to slide 14, in light of this evidence, the Healthy Living, Healthier Communities team in Fraser Health has been asking, what can we do? It seems a stretch for us to influence people's income, and yet it looks like that's exactly what needs to happen if we're going to reduce food insecurity. So throughout the remainder of my portion of the presentation, I want to share some examples of work we're doing in Fraser Health that we hope will address the root causes of income-related food insecurity. We've identified 5 core areas to focus our work on food insecurity, and these are partnerships, planning, capacity building and advocacy, policy development, and surveillance and monitoring. To outline how we do this work, I'll be using examples from 3 of our communities: Surrey on the left of this map, Langley in the center, and Hope to the east. Surrey is a large urban center with over 500,000 residents, while Hope lies in a more rural area, and Langley in the middle represents a mix of the two. We also see that 33% of Surrey residents report household incomes of under $40,000, while that number climbs to 37% in Langley City and up to 47% in Hope. We're quite a diverse region, but we found our strategies to be relevant across a range of settings. So hopefully these will be informative to you no matter which part of the country you're in. So I'm on slide 17 now, the first slide of partnership building. So I want to share with you exactly how community health specialists and others in Fraser Health are addressing income-related food insecurity. And the core component of our strategy is partnership building. All of our community health specialists have been trained in the IAP2 spectrum of public participation, which is shown here. And this helps us wrap our heads around who needs to be involved in our efforts to address income-related food insecurity and how deeply they should be involved. The partnerships that form to address food insecurity in each community look slightly different. You can see a map of some of this on slide 18. One common way this work can happen is through our Healthier Communities partnerships. And these are formal partnerships between Fraser Health and the municipal government that have been formed to address the social determinants of health. They may include school districts, local police, community agencies, or representatives from Aboriginal communities as well. In Langley, food insecurity work occurs through a task group that was formed as part of the Healthier Communities Partnership. So in this case, the group that has come together to address the social determinants of health more broadly decided to develop a focus on poverty reduction and food insecurity. In other communities, including Surrey, where I'm located, there was already a strong community group addressing food policy before the Healthier Communities Partnership was formed. So rather than duplicating efforts, Fraser Health puts our time and resources into working with these existing groups to support their work to address food insecurity. Moving to slide 19. As anyone who's tried to form partnerships knows, it can take time. And we've been fortunate in Fraser Health to have a team of community health specialists who are tasked specifically with building partnerships in the community. So this allows us to learn about community priorities and see how they align with our own goals for health promotion. Eventually, we do get down to the work of planning, implementing, and evaluating programs to address food insecurity, but we know that none of this can happen until strong partnerships are in place, and none of these actions will succeed without the commitment of community partners. So this is why partnership building is at the core of our model to reduce income-related food insecurity. So moving on to slide 20, and the next area of our work is planning, and this is critical to ensure that the strategies we're employing as a community are actually contributing to the outcomes we want to achieve. In both Langley and Surrey, we found it helpful to work through the process of developing a theory of change, and this has been done with support from a collective impact coach from Plan H and Interweave. Basically, this has required that we use data to articulate the problem we want to address, state the impact we want to achieve as a collective, for whom and by when, and identify the strategies we're going to employ and the outcomes we can reasonably expect from those strategies based on the best available evidence. This is part of a formal collective impact approach, and it may not be the right structure for every community, but the basic principles of applying data and evidence and clearly articulating expected outcomes from proposed strategies is something that public health professionals are doing in communities across Fraser region. On slide 21, I wanted to show specifically what the community health specialists and other public health professionals have done to support planning, and I'll share that through some steps that went into developing the Langley Poverty Reduction Task Group's theory of change. I don't know why my slides keep jumping around. There we go. Too far. So as already mentioned, partnerships were established through the Langley Healthier Community Partnership, and this led to the identification of poverty reduction as a priority with a specific focus on food security. There was a need for the group in Langley to reach a shared understanding of food security and its root causes, so the community health specialists gathered information and supported education and discussion within the task group so that all members could build a common understanding of food insecurity to guide their work. The next step in the blue box was to define a target population. So the community health specialist, with support from the medical health officer and our population health observatory, collected and presented data on the level of food insecurity and the prevalence of known risk factors within the community and across neighborhoods. This helped the group identify priority neighborhoods to focus their actions. The next step, supported by public health, was asset mapping. The community health specialist facilitated participatory mapping sessions to identify assets and gaps in each community. And Fraser Health's public health dietitians have been extremely helpful in asset mapping that's occurred in several of our communities as they regularly document the various agencies in the community that are addressing hunger and food insecurity. So based on what they've learned so far, the task group is now developing a community engagement plan to learn from those with lived experience and to better define the problem and the impact they hope to have. And this will ultimately lead to a completed theory of change. So as you can see, there are multiple roles our population and public health staff have played in this community's planning process. I'm on slide 22 now, and Seeds of Change Surrey, the group I work with, went through a similar process. So what I'm showing here is a visual representation of our theory of change. We identified 4 pillars of food security, which are availability, access, food literacy, and of course income. And when it comes to actually planning programs, we found it far easier to plan interventions that address access to healthy food or food literacy. But planning interventions that address that income pillar at the local level has proven far more challenging. So this has led to a great deal of learning on our part to think in terms of economic development. And that brings us to the next stage of Fraser Health's food insecurity work, which is capacity building and advocacy. So on slide 23, you can see some of a definition of capacity building. But before I begin on capacity building and advocacy, I want to be clear that this isn't just something we as community health specialists or public health professionals do to communities. Working in the area of income-related food insecurity is new for a lot of us, so we are constantly learning and developing our own capacity to do this work alongside, and in many cases from, our community partners. Capacity building for us typically begins with knowledge translation, and with support from our Fraser Health librarians, we seek out literature and information on food insecurity and develop strategies to share that information in a way that makes it accessible and applicable. As we gain an understanding of the root causes of food insecurity, the next step is to support skill building so that we can critically examine interventions that are being proposed and design them or redesign them so that they are truly addressing income as a root cause of food insecurity in the community. I mentioned that there's been a great deal of learning with the Seeds of Change Surrey group on potential strategies to address income-based food insecurity. We've had the opportunity to engage with experts from Simon Fraser University in the areas of social enterprises and social innovation. And this has significantly increased our understanding of the potential for sustainable business models to generate income for individuals who would otherwise face barriers to employment. We've realized that we in public health and social services have a lot to learn from the business sector in terms of economic development and income creation. So there are still times when what's needed is direct action by decision makers, and this is where advocacy comes in. At a provincial or national level, we may think in terms of broad changes to social assistance, but there are opportunities at the local level as well. As an example, the Langley Poverty Reduction Task Group did a delegation to the Township of Langley's City Council to voice their support for the idea of hiring a social planner. Previously, the Township of Langley hadn't had one, but they are now in the process of hiring a social planner. And this will improve the capacity of the municipality to work alongside community organizations in addressing social issues. The fourth area community health specialists direct our energies is policy development, and this starts on slide 24. At times, we or other Healthy Built Environment team members are asked to directly comment on proposed policies or official community plans. But in other situations, we participate by taking the time to attend open houses or planning workshops to voice our opinions as public health professionals on the policies that are being proposed. And we are seeing a shift in policies to reflect concerns about food insecurity. The HOPE Community Plan now includes a goal of encouraging a local food culture and healthier lifestyles. Langley has made a commitment to partner with Fraser Health on initiatives to support healthy lifestyles and prevent chronic diseases. And the Surrey Sustainability Charter notes that they will work collaboratively at the neighborhood level to ensure dignified access to healthy food for everyone. And one more example from HOPE, the local food coalition there is partnering with the economic development branch of the community as it develops an agriculture area plan. And this plan will support the local food economy and encourage local food production. But this is being done in order to create jobs and improve access to affordable, healthy food. So it's a sign that these policy documents, which initially appear to address the availability of or access to healthy food, can be expanded to acknowledge the need for adequate income and affordable food as well. Moving to slide 25. I just have one final note on policy development, and that's that some communities, like Langley, are doing preliminary work to develop their own poverty reduction strategies. There may be multiple initiatives taking place in the community that address factors relating to poverty, including affordable housing and mental health or substance use. So there is a need to integrate these diverse efforts into a comprehensive community-wide poverty reduction strategy. And as public health professionals trained in applying a systems lens, we feel we have an important role to play in creating this holistic framework at a local level. So I'm moving to slide number 26 now. And this is the final arm of our strategy, which is surveillance and monitoring. And this is an area we've found public health can play a significant role. At a provincial level, we could use data from the Canadian Community Health Survey. However, BC did not participate in the optional food insecurity module during the 2013-2014 CCHS cycle. So this means that 2011-2012 represents the most recent data available for the province. This has led regional bodies and communities to take it upon themselves to gather data. Fraser Health and Vancouver Coastal Health Authorities carried out a survey called My Health, My Community to gather data on health outcomes, health behaviors, and health supporting environments. And as community health specialists, we've been able to work closely with our Population Health Observatory to translate this data into usable reports for each community, right down to the neighborhood level. Communities have also taken a lead in collecting data at the local level. And as you can see from the example on screen, the Hope and Area Food Security Coalition was able to get more nuanced data at the local level than what is typically seen in provincial or national level surveys. Community health specialists have been able to work with community partners to develop and implement data collection tools and interpret local data. We do this recognizing that if our goal is to change rates of food insecurity at the population level, then it's critical that we have reliable data that can be tracked over time to see if we've achieved this goal. So to conclude, on slide 27, at Fraser Health, we've identified these 5 areas in which community health specialists and other health professionals can contribute to reducing income-related food insecurity. We can build partnerships with community agencies. We can participate in planning through providing data or evidence. We can help build capacity and advocate for changes in the community. We can contribute to policy development, and we can support surveillance and monitoring. So that brings me to the take-home actions. In terms of what you can take from this presentation to apply to your own work, I'd like to suggest 3 actions. First is to share the evidence with your colleagues. There's a growing body of evidence that indicates income is a key driver of food insecurity, and we need to share that evidence far and wide to ensure that we're addressing the right leverage points in our communities. The second is to question the assumed connection between proposed activities and expected outcomes. There are a lot of positive outcomes that are accrued through community gardens and community cooking classes, but we need to question whether there's sufficient evidence to show that they decrease food insecurity. And the danger if we don't is that we slip into a situation of thinking we're doing a lot to address food insecurity, when in fact we're doing putting a lot of energy into improving, for example, social connectedness. And again, it's not to say that's not a valuable outcome, but we need to be clear about what social benefit is being achieved. And finally, if you aren't doing this already, identify who in your community is addressing food insecurity or poverty, and introduce yourself as a resource. And we can't stress enough that there needs to be a real allocation of time to partnership building. So that concludes my portion of the presentation, and I hope that hearing some of the examples of the work we're doing in Fraser Health Region to address income-based food insecurity has given you some ideas for how to approach this work in your own communities. And I just want to thank all of our community partners and collaborators across Fraser Health Region.
Oh, that's great. That's great. Megan, thank you so much for that. That was a really, really excellent overview of how public health can work in really practical ways with our partners and help shift that focus. So thank you very, very much. That's a great lead-in then to our next advisor, and that's Tracy Woloshin. Tracy is a public health dietitian at York Region Public Health. Her focus has been on food insecurity, and she has a real passion for the role of public health in social justice issues in particular. She's really involved in the development of a position statement to address poverty as the root cause of food insecurity as part of public health practice in Ontario, and she will speak about how public health can address inadequate income through collaborating and advocacy, including participation in networks and community groups. And so Tracy, with that, I will turn it over to you.
Thanks, Diane, very much. Am I unmuted?
You're good. We can hear you.
Okay, great. Thank you. My presentation is premised on the understanding that addressing food insecurity requires public policy intervention because food insecurity is a system problem. For more about this, the Chronic Disease Prevention Alliance and Proof Food Insecurity Policy Research Group have recently presented 2 webinars to highlight the increasing rates of food insecurity in Canada and the groups most vulnerable to food insecurity. And there's going to be an upcoming 3rd webinar about food insecurity and health, and these webinars are archived on the Chronic Disease Prevention Alliance of Canada website. The mysterious artist Banksy makes a good point with, and I don't know if you can read this, but it says, "Keep your coins, I want change." When it comes to the situation with food insecurity and how we are currently addressing it, we certainly need change. So my part of the webinar will be about advocacy and public education with the goal of impacting public policies. This slide and the next are thanks to Dennis Raphael and Toba Bryant. These two slides highlight why advocacy and public education are so important when working on the social determinants of health. And this slide talks about when we examine why no effective action is being taken, we see that knowledge dissemination is limited to researchers, public health professionals like ourselves, and policymakers, rather than citizens. Citizens are generally unaware of the problem. Minimal government intervention is seen as positive, like minimal government intervention, and governments aren't under pressure to act. This nutcracker image is from Fran Baum from Australia. The image offers a theory for effective action on the social determinants of health, including food insecurity. That is, that both top-down political commitment and bottom-up action from civil society, like ourselves, are both needed. This points to the need to raise awareness about problems related to health inequity. In doing so, we as public health professionals need to recognize political, social, and economic barriers. For example, the expressed barrier that the expense of social programs is too much for governments to pay. This is where our knowledge of and our commitment to the cost effectiveness of prevention and addressing the social determinants of health come in. And in food insecurity, we have research that shows that food insecurity is a robust predictor of healthcare utilization and costs, even independent of other social determinants of health. That research is from the proof group mentioned earlier. So Diane structured our webinar around take-home actions or action on the root cause. So the first action that I thought to mention was that we need to identify our organization or our partnership, as Megan talked about. This action emerges when you're working on a policy recommendation which your public health unit may not have endorsed, for example. When we're talking about policies such as implementing income support programs or increasing social assistance rates, we're talking about positions that an organization may not want to be vocal about. If that's the case in your health unit, for example, then you need to identify an organization or partnership that is able to be vocal. For example, in Ontario, we have the Ontario Society of Nutrition Professionals in Public Health, OSNPPH. This is the homepage. And it's a member-driven organization and the voice of registered dietitians working in health units in Ontario. And OSNPPH is able to do this kind of advocacy work. Take-home action number 2 is to know what you stand for. OSNPPH developed this position statement, which is premised on the evidence that poverty is the root cause of food insecurity. The position statement asserts that food insecurity is a human rights and social justice issue because we have a very unjust distribution of resources and opportunities, resulting in a lot of Canadians not having enough money to buy their food. For more information about the OSNPPH position statement, there's an archived webinar at the link on this slide. Now I'm on the slide that has proof food insecurity policy research at the top. When developing our position in public health, we try to be as evidence-based as possible. In the area of food insecurity, we have excellent scholars doing the research that informs our program, that can inform our program planning and our advocacy. The Proof project and website provide extensive evidence for us to use. Megan also referred to this research, and I think Karen posted the link in the chat box. This paper by Emery, Fleisch, and McIntyre was influential in leading our OSNPPH group to advocate for a basic income guarantee as an upstream solution to food insecurity. Statistics show that the rate of Canadians experiencing food insecurity is half that among Canadians aged 65 to 69 compared to those 60 to 64. That is, once low-income people turn 65, their risk of food insecurity is halved due to the existence of an income floor for seniors in Canada. And this income floor actually is currently being planned to be piloted as a basic income pilot here in Ontario. But we already have this evidence in terms of the relationship between a basic income and food insecurity. Still speaking about knowing your position, Dietitians of Canada developed their position and recommendations. Dietitians of Canada states that all households in Canada must have sufficient income for secure access to nutritious food after paying for other basic needs. This is an excellent resource for any of us when we're developing our positions. All right, then take-home action number 3, determine your goal. And I put a note here about beware of conflation. Diane has mentioned this and Megan as well. Here in Ontario at our OSNPPH conference in 2014, Dr. Lynn McIntyre cautioned us about conflating income-related food insecurity with the broader definition used for food security. She expressed concern that the broad framing of the problem is inhibiting progress on policies that might better address food insecurity and financial constraints. For example, when the problem is food insecurity, which is about financial constraints and which affects millions of Canadians, then the solution needs to focus on adequate income, and the solution needs to be systemic. For example, the resources cited above under the Know Your Position section identify policy solutions, such as the guaranteed income, to address food insecurity. Community food programs, on the other hand, address different goals, again, as Megan already discussed. So these are some other goals that are addressed in nutrition programs, important goals, for example, vegetable and fruit consumption and food literacy, which are important goals from a public health perspective, but not reducing food insecurity. So talking about framing programs around their public health goals, community-led initiatives such as community gardens and farmers markets don't address the root cause of food insecurity, which is people not having enough money. With that point in mind, and with the point about avoiding conflation of community food programs with food insecurity, would framing programs, as on the slide, reduce the confusion between food security and food insecurity? So for example, community gardens being planned in order to increase vegetable and fruit intake. In other words, we need to be clear about what outcomes can reasonably be expected from a program. Huskin, Orr, and Tarasek have studied food purchasing, food preparation, cooking ability, and gardening, and found that there was no significant association between household food insecurity and respondents' self-rated cooking ability. These researchers conclude that their results raise serious questions about recommendations that programs to improve food skills are part of the solution to food insecurity. And this infographic is on the Proof website. A local example of how this reframing has happened here in York Region is the Community Investment Strategy provides funding to community agencies that serve our residents. The wording under the Community Health Results area used to say food security to refer to community kitchens and food reclamation programs, for example. But we have shifted that language from food security to framing these programs as focusing on healthy eating, programs that focus on healthy eating. For a goal about food insecurity, we need to stop perpetuating the message that charity or community food programs are effective responses to food insecurity, and instead focus on supporting effective policy approaches. So for example, for a goal about food insecurity, I used the Proof website and its definition to create this goal about supporting and promoting effective policy approaches. And the last goal slide about food insecurity is from this JAMA article, which states that in public health, we need to keep our strong voice that historically we've used to improve public health, and we need to use the research and literature to support our work. This article talks about the critical public health contributions that were made in the 20th century, and it identifies these two aspirations to continue to make critical contributions in the 21st century. In particular, current public health problems require solutions related to social, political, and economic domains, which kind of harkens back to our nutcracker model earlier from Australia. And public health should promote social justice and human rights to reduce health inequities. Take-home action number 4 is probably the bulk of our work, and that's about spreading the word. On this slide, I put a flyer from a community event organized by the York Region Food Network to raise awareness about food insecurity and the need for income responses. At that event, our Ontario Minister responsible for the poverty reduction strategy spoke, and one of the things he mentioned was that government, quote, didn't want to get too far ahead of the parade. This is when he was talking about the basic income pilot that's planned for Ontario, that the provincial government announced in the budget last year, and they're planning to implement a pilot study of the effectiveness of a basic income. And in this context of talking about the basic income pilot, he said the government doesn't want to get too far ahead of the parade. So in other words, we need to work on raising the parade's awareness, i.e., public awareness on the need for effective responses. So I think that's where we come in. Spread the word. So this infographic we developed in OSN, the Ontario Society of Nutrition Professionals in Public Health, along with the position statement. This infographic was used at the Ontario Public Health Association Fall Forum and is being used by campaigns such as Put Food in the Budget. And both the position statement and this infographic are available on the OSNPPH website in French and English. And speaking of infographics, this infographic is from the Halliburton-Kawartha Pine Ridge Health Unit and points to the need for income responses to address food insecurity. This health unit has used this infographic with their community partners and local newspapers and radio stations. And it's also been tweeted by several organizations and posted on several listservs, again, about getting the message out. And to wrap up my part, I urge us all not to be shy. Within the context of our organizations, with public health associations, local coalitions, or professional associations, there are many important activities that we can do to promote key messages. This slide lists examples of actions to raise awareness, such as community events, social media posts, or meetings with elected representatives. And all of these, again, are examples of bottom-up actions on the Nutcracker. With the understanding that we're talking about advocacy and that we need bottom-up action, these are the 4 actions that I take away from the work we did mostly with the OSNPPH position statement and here in Ontario that we need to consider in public health. And I just wanted to end with a picture and quote from someone who faced a lot of opposition and was told it couldn't be done when he wanted to implement policy changes. And today probably none of us could imagine not having hospital and Medicare that Tommy Douglas brought in, much to the opposition of some. Thank you very much for your time. Christine, over to you.
Hi, thank you very much, Tracy. That was just a really great example of some practical actions that public health can take and shifting into that social justice and advocacy role. And so with that, yes, I'll turn it over to Christine. Christine Johnson is the Health Equity Lead with the Nova Scotia Health Authority. She is also chair of the Ending Indigenous Poverty Reduction Coalition and the Health Equity Working Group of our Public Health Association in Nova Scotia. And Christine is really passionate about how community development and public health practice intersect and how they need to be part of one another. And so she's going to speak about a recent project where public health was directly involved in calculating the living wage, and how do we use that topic of food insecurity into broader initiatives that address income and equity. And so Christine, with that, I'll turn it to you.
Great, thank you, Diane. Hi, everyone. It's really great to be here, and especially great to be listening in and working on this project with colleagues. I've learned so much already from our existing speakers, and a lot of our experiences are similar. So as Diane said, I'm on slide 53, and I'm speaking specifically to our project in Antigonish titled Working for a Living, Not Living for Work, in terms of how we have focused on income security as a way to address food security, as well as the multitude of issues that we know are confounded with poverty. So just to frame things up on slide 53, from a public health perspective, here in Nova Scotia, we have been focusing a great deal, as many others are, on health equity. And we have a long history of social justice efforts in our province, and in particular in this region of the province as well, northeastern Nova Scotia. And what really gave us a lot of extra kind of emphasis and ability to engage in some of the work is our public health protocols. And they really state that health equity is a foundational standard for public health practice, and that we need to be doing equity-related work regardless of what content area we're focusing on. Here in public health, we are working very hard to figure out what that looks like. And this project is an example of one of those areas. One of the things that the protocols ask us to do is to really look at, the establishment and implementation of healthy public policies and supportive environments which address our social determinants of health in order to improve our health and reduce inequities. So it's very clearly spelled out as a directive, but what's often more challenging, of course, is how to go about doing that. So the example I'm sharing today provides lots of sort of examples of the types of ways in which we need to engage differently with the work in order to achieve that goal, such as by working in partnership, working with diverse sectors and areas, sharing information, building knowledge, all of those great suggestions that have been shared already. So why the living wage framework? So how did we sort of land on that for slide 55? So this cartoon here, the man or the individual on the top is saying, keep working, it's the only way out of poverty. And for a long time, we did often think of employment as a key way of getting out of poverty. Go back to school so you can get a job, and you'll find your way out of poverty. Those are the messages we often hear, but what we're seeing now, we know that employment is no longer a guarantee to having sufficient income and to having food security. So just as two examples, the 2014 study, or the summary through Proof, which looked at the rates of food insecurity in Canada, tell us that just around 62% of the food insecure households in Canada were reliant on wages, so they are earning wages. And also our most recent hunger count through Food Banks Canada in 2016 tell us that for users of food banks, 1 in 6 of those households are supported by employment and wages. So employment and wages is no longer a guarantee out of poverty. So on to slide 56, just to tell a little more of the story of why the focus on what living wage had to offer us and our focus. This really reinforced for me some of the points you made there, Tracy, around framing. Framing up this work has been both very important but also very challenging, even within our own group, in terms of getting on the same page about what exactly we are working on and focusing on and why. So over 5 years ago, the Antigonish Poverty Reduction Coalition had done a community needs assessment around poverty and the relationship to health. And the quote on the slide reflects just one of many rich sort of descriptors and experiences that people use to talk about poverty as an issue in our community. And then the puzzle pieces identified, the main issues. So no surprises there. It's in many ways a fairly typical list of the determinants or social terms of health, with some missing. But the issues that they talk about, food security is there, income security, childcare, housing, transportation was very big in our area being rural. So out of that work, we have had a number of different initiatives that have spearheaded, like a community-based transportation and a housing society. And we had a very robust and existing food security coalition, and still do. And so for the Poverty Coalition, what we tend to do is look at the intersection of these issues and focus a lot on income security. So one of the first things we did to focus on income security actually was to have Senator Art Eggleton come and speak about the concept of a basic income, and we're still very much advocating for basic income. But then we also became aware of the living wage work. So the first living wage study was done in the province in 2015 in Halifax by the Canadian Centre for Policy Alternatives and the United Way of Halifax. We wanted to learn more, and so we reached out to the CCPA to look at the work and what it could offer. And why we became really engaged in it or attracted to it is because the living wage framework and calculation allows you to set a benchmark. So for the reference family in which the calculation is done, we can establish a benchmark of what it takes to live well in our community. So regardless of whether that income comes through wages or social assistance, or the cost of living are managed through more effective social policy, doesn't matter. We need to know, once we know that benchmark, we can know the multiple policy levers and how far we are from reaching it and what we can do to get there. So that's really why we focused on that. So I'll go into what is a living wage, just so you know exactly what we did. A living wage is the hourly amount that a family needs to cover their basic expenses. So as I said, what does it actually cost to live and support a family in a specific community? That's the other piece about it that's great, is you can do that calculation for your specific local context to give you a clearer picture of what's going on and support some of your local level advocacy. Within, what do we mean about covering basic expenses and allowing them to live and be engaged in a specific community? We're talking more than just meeting your basic needs for life. We're talking about social inclusion. We're talking about supporting healthy child development. We're talking about, having enough income to meet your basic needs as well. So it's a bit broader when you look at the calculation than what most often is seen in what's listed as a basic necessity. And again, that was important to us because we heard many times that, that the idea of social inclusion is often the outcome which has the largest impact for people living on low income. So it's important also to note that a living wage is not a minimum wage. It's also not the same thing as a guaranteed annual income or a basic income policy. It's different. It is wages. When the wage is calculated, generally a campaign would suggest that that wage be paid on a voluntary basis by various sectors. And so usually there's a campaign that occurs to encourage that. So when we did the calculation, slide 58, our reference family is a family of 4. All family members are healthy and able-bodied. We have 2 parents working full-time, which is 35 hours a week. And one of those parents is in part-time education at a local community college. There are 2 children, a 4-year-old and a 7-year-old. So they require regulated childcare as well as after-school care, before and after-school care, and summer camps. So why the 35 hours a week? That was really important, again, when we're thinking about the idea of actually living and not just existing or getting by, having a bit of work-life balance and allowing time for things like school and continuing education or being engaged in the community. And we do know that for 58% of workers who are paid by the hour, they work on average about almost 30 hours a week. For those who are salaried, it's on average 36.4. So it's in line with what people in the province are working. So on slide 59, I know that's probably not that easy to read. The full details are in the report, and I won't go through all of them, but essentially this is the formula. So it looks at what are the different things that go into figuring out what that wage is. And not surprisingly, lots of things in there you can expect. So the cost of food using our National Nutritious Food Basket calculation is in there, the cost of owning a car, clothing, etc. There are funds included for social inclusion. So we do have some money in there, and as I mentioned, parent education, a little bit of money for emergencies as well. So a lot of the data we were able to use existing data sets to apply to our local area, to our community. But for some data, we needed to do the collection ourselves, such as childcare. So we had to call and figure out what the rate would be, because we don't have that kind of information on a collected regularly at our level. So with the results, just to say as well, it's important to acknowledge as well what's not included. So we don't have any debt repayment in there. We don't have any retirement savings beyond Canada Pension Plan. We don't have savings for children's education, and we don't have savings maybe to own a home or any special health care needs or dependent care needs. So there's a lot, when we know and think about the diversity of our families and our communities, there's a lot of things that are not reflected that would be additional costs. So in Antigonish, we did this calculation in both Antigonish and repeated it in Halifax as well. So the living wage worked out to be $17.30 an hour, or $31,486 annual income per person per year. So our reference family of 4, those 2 parents need to earn almost $63,000 to live decently. And we're not talking about all of those other things that people might expect to be normal parts of living as well, like retirement savings or a down payment for a home. That's a high number. That was shocking for a lot of people. Just as a reference point, if we had those same 2 parents working for minimum wage for those hours, they would earn about $40,000 a year. So the gap between what our minimum wage is and what would be needed just at that basic level is $23,000. Halifax cost of living was a little higher. The wage is over $19 an hour, and the biggest differences, what was contributing to that cost, were childcare expenses being significantly higher in the city, and housing just a little bit higher. Part of the living wage framework also encourages you, of course, to get at the context and the lived experience. So we mentioned that there's a lot of context and diversity of our families that aren't reflected in that calculation, and there's also a lot of what does this actually mean for people from a first voice experience is important. So we did hold a discussion group to get a sense of get their reaction to what went into the calculation for low-wage workers, but also look at the various issues. And not surprisingly, we got a multitude of issues come up and challenges around childcare, whether it's available, whether the regularity of hours was another big one. Being able to have a phone and internet and enough money to feel included in your community. And not surprisingly, people brought up food security. So they talked about, not being able to buy full price products at the grocery store, really just getting what's on sale, making do with what you have. So a clear link being made there for people living on low incomes, working for low incomes, and experiencing food insecurity. And one of the quotes I really liked where they talked about, we asked, what would a living wage mean to you? And they said, I think it would be living without being stressed to the max and making yourself sick. So also making that connection to the health implications. So what have we done so far with this work? Other than conducting the work, we've done a number of media interviews. So we had a release and we had a very good uptake by the media, both television, local radio stations, and newspaper. And where we're working at now is around our dissemination and engagement plan. So really thinking about, well, who are our main audiences that we want to communicate to and that we need to engage in this work? And one of the areas that has been most challenging for us, which has been mentioned already, is the business sector and the private sector. This is a partner that we often don't work with, and yet when we start talking about wages, we need to have them at the table and as part of the conversation. And so that's been a piece of work that we've had to put a lot of time and attention into, and are still working very hard to even establish some of those partnerships, let alone be working to full function in them. So that's a big piece. So that did make me think about the concept of being a boundary spanner. And so Catherine Ma, in her interview in the Public Health Speaks document that was shared through the NCC, does reference boundary spanners and talks about, our need to hone our abilities to speak in a language of different sectors, to do that policy brokering as much as possible, and consider the different stages of readiness. And again, that's something that I think with public health we need to start working a bit more on. Two other things that were really critical is connecting the pieces of the puzzle, so showing those interconnected linkages, as well as being solutions oriented. So making sure, one of the things we did in the report was sort of share our vision for what Antigonish would be like if it didn't have poverty. So that's one way of sort of flipping things and looking at the positive. So just skipping on, just 2 slides left. So I wanted to mention some work that's been done by public health colleagues here. Many of you would have either heard of or been engaged in the Food Secure Canada campaign, Eat, Think, Vote, during our last federal election. And our public health nutritionist, Karen McKinnon, worked with our Food Security Coalition to host a very robust community discussion with all 5 of our MP candidates. And we used a lot of our existing research and key messages to establish that discussion. And then during our most recent provincial municipal elections, one of our health equity promoters, Celeste Gotel, worked with a local health equity action group to develop some fact sheets, which were targeted at, and candidate conversations, targeted at municipal level candidates, to look at the issue of food insecurity, what it means, and how municipalities can engage with that issue. So my take-home actions really are to emphasize developing our capacity to be the boundary spanners. So how do we understand our own perspectives and worldviews, and be able to seek to understand and engage others' worldviews, particularly the unlikely partners, or what have been our unlikely partners to date. It's important to understand the intersectionality of these complex issues, but also prioritize and be clear about focus and intent. So sometimes we can get lost in our work because the issues are so complex. So food security, poverty, such a big issue. And then sometimes we lose sight of, really what is it that we're trying to do and what's the outcome we're seeking. And lastly, know and use what public health has to offer. So be really clear on what our public health lens is, and use our influence. We do have a strong voice, and people respect the work, and so we need to be able to use that. It's going to help if we have key messages that we can develop and share to appropriately frame the issues. And we also want to not just share the problem, but share and offer the solution. So what are best practices and solutions that have worked elsewhere, and do a good job of sharing and saying exactly what it is that what change we're seeking. So that's it from me. Thank you.
Oh, okay. Thank you very much, Christine. That was, when I first learned about this work, it was really surprising in a way that, public health was so involved with advocacy work and with income policy related work, and that they supported your time, and they do support your time to be chair of the Poverty Coalition. That's a real example of some tangible shift in focus that can happen. So just before we get to questions, I want to just highlight the next 3 slides, and that's 3 products that the NCCDH has just released. This first one on slide 66 is Learning from Practice, Advocacy for Health Equity and Food Security. And this really highlights the work of 2 organizations, the Ontario Society of Nutrition Professionals in Public Health and Food Secure Canada. OSNPPH developed the position statement that Tracy referred to, along with a set of policy recommendations to address adequate income as it relates. And Food Secure Canada developed a campaign called Eat, Think, Vote to advocate for national food policy. And so this is a resource that offers practical considerations for advocacy roles, along with discussion of supports and challenges to the work and the lessons learned along the way. Along with that, we also have a resource called Public Health Speaks that Christine referred to, and this was a really cool project for me to work on. I interviewed Catherine Ma, Melanie Curine, and Lindsay Davidson, and this really is a summary and highlights of my discussion with those three experts, and it's really around how to do that shift in public health action towards the more upstream types of solutions. And we do include in this document some really practical actions for public health practitioners matched with the 4 roles of public health to address health equity. And then the third one is also just released, called Upstream Action on Food Insecurity, a curated list. So in working on the other 2 documents, there were a number of really useful resources came up. And so what we've done that is put all of those resources together, organize them according to the public health rules for health equity, and are providing links and letting people know about them. A special note is that there is a section in this document that focuses on the northern food security and security issue and resources that can go along with that. And we've done our best to include resources that are in English and French as well. So please check out those from our website. And with that, I will move to some questions. So we did have a few questions come through. I'm just going to go to one second here. Sorry, I've got them off on the side here. So one of our first questions came from Pat Vanderkoy, and it was, have you submitted the work to the federal government? They're currently in consultation with the poverty reduction strategy, and there's some question about will responses be submitted when the consultation's in progress. Pat also, if you go back up in the chat box a little bit, provided a link to more information about that policy. So to any of our presenters, I know that NCCDH is not necessarily planning a formal submission, but it is something that I'm going to take back to the team and talk about what our role for that might be. But can any of our presenters comment on having a voice when it comes to an actual national poverty reduction strategy? Are any of you have any plans to take action?
This is Megan from Fraser Health. This has come up actually in, I think, a couple of our communities, certainly the one I work with in Surrey. And so advocates and supporters within the community have been doing some work to engage in that process. As an organization ourselves, I don't think we have been, but working with our community partners, that's really where we see ourselves having some input.
Yeah. And I think that maybe that could be where some of these materials and some of our role in public health could be to support our partners to do that. Some public health practitioners are fortunate to be able to do that kind of work directly, and where we can't, then we want to support our partners for sure. So there was a question from Angela Dobson. What stage, I think this is for Fraser Health, saying congratulations, but it's awesome work. And so what stage are you ladies at the three different areas? And can you comment on some of the stumbling blocks that have worked, that you've had to work through, and can you sort of give any tips from that?
Sure. So I think all of our communities are at slightly different stages. The examples I was drawing from were some communities that are a little farther along in really wrestling with this idea of addressing income-related food insecurity. In some other communities, there aren't yet specific tables that address food security, and so those conversations are happening more at other tables that address social determinants of health. I think one of the big stumbling blocks that we've had to overcome is really building energy at the local level to address this issue. As I think all of the presenters have noted, sometimes we're really good at developing food-based interventions through a charity model, but to actually address something like income or living wage or basic income, we see those often as something that needs to happen at the provincial or the national level. So getting partners on board to take action and do real tangible work can be difficult. In Langley and Surrey, we've really benefited from having support from BC Healthy Communities and having coaches and resources from them that really direct us in how to think about sticky issues in the community and how we engage those unlikely partners have been helpful in giving some structure to the process so that community partners can see that there is a clear process for doing this work, rather than everyone kind of sitting around a table looking at each other and asking what we can do. So engaging in some of those concepts around collective impact and sticky issues have been helpful for us.
Okay, thank you. Lara Miley had a question around, or well, comment first about community health centers building strategy on the Canadian Index of Well-Being. And so she's wondering if there are others that are doing work to influence one of those domains of the Canadian Index of Well-Being, democratic engagement to inform and influence. Can anyone else comment if they're doing work on Canadian Index of Well-Being? Lara, maybe if I maybe haven't reflected the question properly, if you've got some clarification maybe that you can provide in the chat box, that would be great. You know, it would be interesting to know about building strategy in terms of indicators. So if people have something to offer around that, then maybe we can add that into the chat box. So there's a question from Suzanne Galeshoot. Are we planning on tracking policy action that moves into intermediary income approaches? So she makes a really good point that often the social enterprise projects, which focus on local food environment, still place the paradigm shift in the realm of food policy. And so then sometimes further shift into income policy needs to be rooted in food programming and food policy. So can anyone make a comment on that, either if they're tracking policy action or you know, how that shift needs to really be rooted in food-specific type of policy? Fraser, Health Ladies, have you guys had that discussion at your community tables?
So there has been a little bit of discussion of that at the Surrey table that I sit at, and it's recognized that it is really hard to track changes that are going to take a long time, as a lot of our work in public health does. So another area where we've been building our capacity is in the area of developmental evaluation, in terms of understanding and tracking where decisions are made, how they're made, what went into those decisions, and where all of the little nudges are happening within the system that are contributing potentially to larger changes overall. So I think developmental evaluation is one area that we've found really helpful to address some of those big questions.
This is Brenna, and I'll just add to Megan's comment there. Just in terms of that's at the local level, she was mentioning the developmental evaluation. At the regional level and the health authority level, we also do report on our healthy community partnership work. So as Megan was mentioning during the presentation, our communities are all, while the work is structured quite differently, many of them are based, the food security work is based out of the healthy community partnerships. And so we do submit quarterly reports, which would include any policy changes through that reporting up to the Ministry of Health, which is through quarterly reports. So hopefully we do capture the policy work that is going on within our communities through that.
Okay, thank you. Hopefully that was helpful. So Giselle Powell had a comment and a question. So the comment was around the living wage is great, but how does that translate to divorced status? And statistically, women once divorced with children are more at risk to be living in poverty. Lara offered information to fill that in, as you know, that the living wage calculation can be done for a single parent for various compositions of families. But Christine, are you able to comment on that, about how the living wage calculation can be, how it applies to divorce status or even to different subgroups in the population?
We haven't, in Nova Scotia, we haven't done anything other than that reference family of 4. We have definitely recognized the gaps that, that's a pretty standard family, scenario that may or may not actually exist most of the time. And we know that people most at risk for low income, might not be reflected in there. So no, I don't have any particular familiarity with those adaptations. Hopefully it can be done. And there was also that comment and question about where does this leave First Nations, and thanks for bringing that up, because we have recognized that this is a very big gap area, that, you know, it's not the same policy options that we're looking at. But again, I think what was helpful for us is even just to have a picture that for that family of four, it takes, you know, $63,000, and you could try to extrapolate. It's not a perfect science if it's one parent and two children or whatever, or a larger family and that kind of thing. But what's most important is seeing that, you know, how far or how inadequate our incomes are. And I think that's where we're trying to bring in some diversity in terms of the population groups we're speaking to and with, in terms of, you know, how far are people? So if people are being supported by income assistance, what does that family look like, and how far is that from the benchmark? If people are First Nations on reserve, what would their not working, what would their income look like? How far is it? For people who are waged in our communities, etc. So trying to get those basic demographic statistics to do some comparison so that we can really see how far we are from really more of the standard of living that we're going towards.
No, and that's really good, Christine, and thank you for addressing that next question on about how it applies to the First Nations Reserve. It's difficult because the First Nations Reserve piece is federal policy as opposed to provincial policy in a lot of that where the other income pieces lie in a lot of other provinces. And I know that depending on the province, and sometimes even within provinces, depending on the communities, public health may or may not have jurisdiction or agreements for working in First Nations communities. So that presents even one more barrier to go through. So yeah, so I guess one of the, you know, hopefully one of the solutions or one of the ways to consider that would be, you know, forging those relationships between public health and the First Nations communities, and then, you know, figuring out how the income policy piece applies and advocating at the federal level. But I feel like it's a giant issue. Okay, we had a question come through from Pat Vanderkoy. How many provinces have mention of food security in the work of their provincial ministries of agriculture? So I don't have an answer for that. I have no idea. Does anyone in the audience have experience working with the agricultural sector on the food security and security piece? If you do, please offer it up in the chat box. Can our speakers have any expertise or knowledge about the agriculture and agri-food industries and what the intersection could be?
Within Fraser Health, we certainly have been looking at partnerships with the Ministry of Agriculture, and we have had a regional agrologist come to one of our communities to do a delegation to discuss the economic and local benefits of supporting agriculture. In BC, there was also a publication on agriculture and health, and I'll just post that in the chat box. But just a sort of word of caution, there's definitely some of the topics that have been discussed about that inflation of the direct links between food security or local food programs and the links with health. And so just a word of caution with that document, but I will post it in the chat box.
That's great. Thank you. Okay, another question for our Fraser Health girls, actually. Lynn McIntyre posted a piece of information that I didn't know, that BC's last budget just announced $10 million for food banks to get fridges and trucks to support the tax credit given to farmers to donate to the food banks. So that creates a lot of stress on food banks to absorb the fresh food. So we're just wondering what you ladies from Fraser Health are thinking of that in light of the work on this income-related focused work that you're doing.
Hey, it's Laura here from Langley and Fraser Health. One of the things that one of our challenges with our food bank here in Langley around that specific initiative is space. So they don't really have, they could have all the money in the world, but they don't have any space to store the food, even with, that's a challenge here in Langley for sure. And I think when we're looking at, yes, we're getting now into, food charity type models, and if I go back to what Megan was speaking about before around, building the energy to actually make some changes in the community around food security, it's really easy to get people jazzed about food charity work, and it's much more difficult to get them focused around the income piece. And I definitely see in Langley where I feel like I need to sort of strike a bit of a balance between the two, because we have a lot of social service providers that are trying to work with clients who have an immediate need for food, and it's very difficult for them to engage in their services when they're hungry. And so they really feel a drive and a passion to address that issue. So I'm really trying to strike that balance between, not losing sight of income and trying to move towards that and addressing root causes, but still able to do some things that sort of address these immediate needs.
Okay. No, that's great. Thank you. Thank you for responding to that. I think that might be the end of our questions. There have been a few things posted. Lara Miley posted an example of living wage for single moms supporting 2 kids in Brantford, so you'll see that in the chat box. Pat Vanderkooy has posted her email at Dietitians Canada, I think looking for some information on the comments around the Ministries of Agriculture and the agri-food industries and the intersection there. That would be great. Brenna and Laura have posted a link to the full report from the Public Health Services Authority in BC. And I see one there from Jadwiga. Okay, so that's a link to a Global Institute for Food Security group in Saskatchewan report saying that the focus is food production based, but it's there for consideration and for review by everyone. Have I missed any questions? I'll pause just for a second and wait and see if anything else gets posted. In the meantime, I've put up the slide that has our evaluation survey. This is a hyperlink, and so you can link directly to it from here. But I do see actually that if you have the hard copy slides in front of you and not the hyperlink in front of you, then that's not going to work very well. So I'll post it one more time in the chat box. There we go. Any last questions? And maybe while we're waiting for that, I'll just ask our speakers, do you have any last comments that you wanted to make? I think what I would like to say is that I've really appreciated when we started putting this webinar together, it was difficult to find some good practical examples of action that can be taken on an income level, and it seems like the examples we came up with were really perfect, and they put together a really, really great picture of the variety of things that can be done. It feels like we're at a really interesting point from a practice perspective, that there are some practitioners and agencies that are really making huge strides, and then there are others that have a lot of barriers. But there's certainly a willingness to consider different ways of doing this kind of work. And I really found working on the products, 2 out of the 3 products that we've just released, I was directly involved in, and doing that work has really, even for me, opened up a lot of possibilities that I hadn't previously considered. So I'm appreciating things sort of as a package right now. I guess with that, I will I've got a thank you coming through. I'm certainly happy to send the slides. If anyone else wants to put their email address in the chat box there, maybe we'll leave that open for a few minutes. And we're happy to send the slides out. And please fill out the evaluation survey if you can. And I wanted to say a huge thank you to our speakers. I really, really appreciate all your work and time and effort in putting this together. It's been a really great, great discussion today. So thank you very much. And with that, I think we will we'll sign off. Thanks, everyone.
Great, thanks.